everybody, we're back, and Lisa tells us that we do have a question.
How long a period of time would you consider a change in a person to be a change versus an adaptation to something, a new living space, new roommate, seasonal change, etc.?
Okay, well, first off, we want to see at least a 6-month assessment of that change still being in place, and you want to rule out, all your reasons that you just mentioned. Is this because people with ID or DD, Down syndrome, it takes them longer to adapt to a new living environment or a new roommate, so they need some time to adjust to the new circumstance. But in 6 months, if that circumstance is still happening and you've ruled out medical reasons, you've ruled out change in living circumstance as a reason, then you start looking at possibilities of dementia.
Or depression.
Or depression, yes.
Could also be there. Okay, were there any other questions? Okay, we're going to move ahead. Again, if you do have questions, please go ahead and type them in. It won't disrupt the presentation at all. We're going to be looking at some of the standard tests that are frequently used to assess dementia in the general population of aging individuals. These tests may not be reliable measures for someone with IDDD or Down syndrome, and they may need to be modified to take into account the person's baseline abilities.
The one test we're going to look at is the SAGE. It's the self-administered Gero-Cognitive exam. There's many versions of them online you can download. It's a useful tool for a family member or a person to do, but as it says, it's a cognitive exam. That means that person has to have the functioning and cognitive abilities to perform that kind of a test. So for someone with moderate to severe range of intellectual disability, and does not have the reading and writing and math skills that the test would entail, it's not an effective tool. Someone with mild intellectual disability and has some reading and writing skills, the test is a useful test. But otherwise, it would have to be adapted to the person. But we're going to look at what that test is. It's a 4-page test. What you're looking at is you're starting off with just basic questions that the person should be able to answer about criteria about themselves, any recent depression, strokes, things like that, balance problems. They're looking at what kinds of things may have happened that could have made a change in their life. So all of the SAGE tests online, you'll see basically the same thing, a section of questions about environment and changes in healthcare. The next section is going to test memory. So you're going to ask for things like, what is today's date? Now, can that person read and write that kind of a question? Or do they need someone to read that to them? Can they actually tell time and date? If that person never was able to do that, this again is a test that they're never going to be able to pass. Naming some common pictures. Now with Mike, when we did tests with Mike, we did the Downs mini mental exam, and we picked pictures of food items because he knew what he would recognize a picture of a food item. Someone may not actually recognize what's here in this particular test. The next area you would look at is writing 12 different fruits and vegetables is the sample we're using in this one. It could be 12 other words. It's just looking at what kinds of recall of words that you have of common items that you would associate with. The other tests are math and spatial use of space kinds of tests. If that person is in the moderate to severe range of intellectual disability, there's no way they're ever going to be able to do this. These are really geared for someone from more of the normal population to rule out the start of a dementia. Basic math skills. I had to really think about how to do some of these myself because I tend to do my math skills on a calculator. But those are all things that you have to take into consideration when looking at this. But that's what it's testing is cognitive skills, reading, writing skills, basic math skills, and if that person's never able to do those things, this kind of a test is not going to be useful to you.
So, if you're bringing the person that you're working with to the doctor and that doctor wants to do a dementia assessment, it's good to have your baseline information with you, so you can say to the doctor, this person was able to tell the day of the week and the date and what year it is and who the president was. They were able to do that. It says right here they were able to do that last year, and now the person is confused. Now, the other question I want to ask you, Linda, you said there were a lot of these available, a lot of stage tests.
Yes.
So would it make sense to kind of surf the web and maybe find one that might be more appropriate to the individual
You
you're
would have
working with?
not for someone that doesn't have. All phage tests are going to be testing basic math skills, reading, writing skills, and looking for diminished, when you're scoring it, you're looking to see what changes in those areas. So if you never had reading, writing, math skills, the test is never going to be useful. So it's really for someone who's in the mild range of intellectual disability or someone in some normal population. So in this population of people, it may be that have limited use.
But I think it's still important to be aware of what is being evaluated in the regular population. So
Right. So you know what you're looking for.
You know what you're looking for, and that when you do take someone to an assessment, you're able to speak knowledgeably about what's going on.
Right.
Another tool that can be used is called the mini-cog, and this can be administered informally by someone who knows the individual well. And it can be a reliable indicator of mild cognitive changes. Again, this is not going to be a diagnostic test, but it's going to give you some information that you could then bring for a more formal diagnostic assessment. Research shows that it has an 83% rate of accuracy, and I guess that would be, if somebody does not score well on this or scores in a way that indicates some cognitive changes, it's probably likely that the doctor is going to find something, or the psychologist is going to find something.
It's defining whether you should pursue that next step with a physician. That's going to do a more detailed come to the test.
So the test has 3 parts. You're going to have the person listen to 3 words, then they're going to complete a clock drawing. And again, like with Linda's person, Mike, he never could draw a clock, so you would probably eliminate this if you were
It's not an appropriate test for him at his functioning level.
And then you're going to, after they do that clock drawing, you're going to ask them to recall the 3 words. So let's say you're going to ask the person to carefully listen to 3 words. We used as an example here ocean, book, and desk. What would be the most sensible is to use words that that person is very familiar with and uses anyway, maybe objects that are in the room or something that the person is going to recognize and be likely to remember. You're going to have the person draw the clock. You can just give them a piece of paper with a clock on it, like a round circle, and then you would expect them to be able to write down all 12 numbers and have the hands pointing to a specific time. After they've completed the clock drawing, you're going to ask them to repeat the 3 words, ocean, book, and desk, or whatever 3 words you've selected. Now, when you score it, you're going to look at the word recall score. They get 1 point for each word recalled, which would be a maximum of 3 points. And then the clock test is considered normal if all the numbers are present and listed in the correct order, and the hands represent the correct time, and they would get 2 points for that. Total score, if they get between 0 and 2 points, there are some symptoms of dementia present, and additional assessments would be indicated. If they get 3 to 5 points, which means they've remembered all 3 words and drawn pretty good representation of a clock, then you don't have to be concerned about symptoms of dementia at this point. So now there's also an Alzheimer's clock draw test.
So basically the clock draw, if the clock draw test it's just the clock draw test instead of the mini-cog, which involves recall skills. You're drawing a clock by hand. It is a useful screening tool for early detection of mild cognitive impairment. The test differentiates between normal aging and possible dementia. If the results indicate a decline in abilities or an unusual representation of the clock, it's an indicator that you need further testing. Now, for an example, when we took Mike to see the psychiatrist every 3 months to monitor where he was at, we didn't do a clock draw test with him because he didn't know his numbers. He didn't know how to make his numbers. But he did know how to take that circle and make a face. and that's how we tested him. We had him fill in where the eyes, the nose, and the mouth would be. He could do that consistently well every 3 months when he was tested until as dementia started to develop, because he went on to develop Alzheimer's. The eyes were where the mouth was, or something was in the wrong order. And we were able to use that as a similar concept. Placing things in the correct order it's a similar concept as the Clockwork test, but for someone that has less capabilities.
So we provided you with PDFs of some of these tests, and you can also access them online at Resources for Integrated Care. So we encourage you to download them and to become familiar with them, because they can be quite useful. So another test that's a predictor of cognitive decline is the simple balance test, and this helps predict a decline in memory and brain function in people with dementia or Alzheimer's. Caregivers might initially notice that the person is having difficulty performing tasks that require balance. This is something that they would want to bring to the attention of a doctor during a wellness visit, or in a congregate care setting, you would want to share it with a nurse or another healthcare provider. The research was conducted by Dr. Eve Rowland, and it suggests that there's a link between physical performance abilities and cognitive decline. People who were diagnosed with Alzheimer's disease had exhibited an abnormal one-leg balance test over the previous 2 years. So it does have some correlation with the development of Alzheimer's.
And the other thing we're still trying to show you is that these standard tests are not always useful in someone with a severe or moderate level of intellectual disability. Mini mental state exam for the this is a test that requires someone to have a higher intellectual functioning. The person must have functional communication skills and orientation as a baseline. It's not useful for pre-existing moderate to severe impairments. It tests individuals' orientation, attention, calculation, recall skills, language, and motor skills. If you didn't have all of those skills to begin with, then it's not an appropriate test. But what we did talk about earlier is the DMSE, which is Down's Mini Mental Status Exam, and that's geared towards that person's baseline. So if that you would have at the start with that baseline, you know what objects they could recognize, you know what kinds of questions they could answer. Like in the case of Mike, going back to my one person that I referred to before, he lived with caretakers all his life. He didn't live with his natural family. He lived in the community, and he could work and he could do things, but he never lived with his natural family. So when you asked him for what's your father's name, what's your brother's name, he didn't know those names. He didn't know who those people were. But when you asked him who his caretaker was, he could tell you that name, or who his roommate was. What is your roommate's name? Those are questions that were geared more towards him. So that's how you would make the test related to his capabilities, rather than just follow a test that is not going to provide a functional assessment. The MMSE is completed by a healthcare professional. We gave you a site on here of where to retrieve it, and I believe we did give the PDF on it as well. So if you would look at the test, you can see how it's scored and what we're scoring under. I mean, you got if you have your PDF up, there's a maximum score number for each of the areas you're testing. This particular test we incorporated was the Folstein. There's many versions of the Mini Mental Status Exam. This is a very some of them are on 4 and 5 pages of paperwork. I particularly like this one because it's 1 page. The maximum score is 30, and each area has a scoring point. The beginning questions are what's the year, what's the season, what's the date. You don't have to ask every single one to get that score of 5, but you need to know, what was that person able to answer before, and this is where you start your baseline on it. What are we in now? Is it a state, a county? The examiner gives you 3 unrelated objects, and you're going to ask for the person to name those objects. Counting backwards is a skill that you lose with Alzheimer's. You're no longer able to count backwards. Well, if that person never could count forwards, you can't test them on counting backwards. You have to give an appropriate. If that person could only count to 10, well, that's how you're going to set up the test. And it goes through each thing. Show you simple objects. How is that person naming those objects? It's common in Alzheimer's where if you they can no longer name the object. It's called anomia. It's the absence of the ability to name an object. And so they wouldn't, instead of saying you hold up a pencil, they're not going to say pencil, they're going to say that thing that you write with. It's a way of expressing, because they're naming things, they start to name things by function, not by the name of the object. And as you go through the test, it's a portion on here to copy an object and to be able to draw it. Again, it's a thing that they have to have been able to do prior to this. Otherwise, it's not a useful test. You have to change it and adapt it to the functioning of that person. And there's a way of scoring it as you go through. You're going to give them a score for each area, and if you have a score of less than 24, it's considered abnormal. If you score less than 21, it's an increased odd of dementia. If you score over 25, you have a slightly less odd of having dementia. On the severity score, you have 24 to 30 means no cognitive impairment. 18 to 23 means a mild cognitive impairment. 0 to 17 means a severe cognitive impairment. And that's basically on that test. I'm going to change to the next slide. Screening and comprehensive diagnostic exams to assess by you on early screen for warning signs is followed by a complete physical exam. Components to include in your screening are family and personal histories where available. Medication history is important to look at because there are many meds that may be confused with dementia, and it's not dementia, it's a side effect of the med. When you do your physical, you want to also include in it a neurological and psychological exam, annual vision and hearing screens, vital signs, sleep and weight monitoring. The lab tests you want to include are CBC, a complete blood count, a fasting blood count, liver function test, ESR, thyroid function test, folate and B12 levels, urinalysis, any drug levels as appropriate based on what drugs they're taking, an EKG, a chest x-ray. If indicated, if you're seeing a dementia or you suspect dementia, you want to start looking at a CT or an MRI. And PET scan is a very expensive test. I mean, that's not a test you would pursue unless you had a clear decision of dementia existing. Determine dementia on alternative diagnosis based on the test results, and again, you're always using a multidisciplinary approach.
Some of the other annual screenings and health maintenance baselines that you want to provide for people or assure are provided for people would be mobility and orthopedic screening so that you can rule out gait or balance disorders. These are especially important in people who might have cerebral palsy, Fragile X, or Noonan's. Noonan's is, I guess, a somewhat rare genetic disability, and sometimes it is associated with intellectual disability, but not always. Many people who have Noonan's also have normal intellectual functioning. It's hereditary, but it may also have some neurological issues that affect seizures that result in a gait instability. You also want to do a fall risk assessment, especially if the person has a history of 2 or more falls in a year. If you recall, frequent head injuries also place a person at risk for development and dementia. If a person does have an increasing history of falls, you want to evaluate for the med profile to rule out any drug use that may be impacting balance.
Okay, some other suggested tests, I don't believe we mentioned yet. The Atlantic Axial Instability Screening in Down syndrome. It's a baseline as an adult with a C-spine X-ray, and you repeat it annually if that person was symptomatic on that baseline. Once it's ruled out, it's ruled out. But if there is an indication, then you have to keep monitoring for it. Osteoporosis screen, which is the bone density study or bone density scan. Medication regime review for potential interactions or contraindications. You should be reviewing at least every 6 months, or if a problem is noticed.
And again, with people who are aging, medications and osteoporosis become increasingly more likely, and you want to be aware of any of the changes that are going on, and that would be part of a differential diagnosis for dementia as well.
Yeah.
which brings us to another important differential diagnosis, and that's teasing out the difference between dementia and depression. Differential diagnosis, as we've been discussing, can be very, very complicated if you're working with someone who has an intellectual or developmental disability. Many times the individual is showing symptoms that may look like dementia, but they're actually symptoms of an underlying depression. Depression and dementia are linked in a number of ways, and they may present with similar symptomology. Dementia may also occur as secondary to depression, they're often mistaken for each other, even in the general population, and the statistic on that is between 10 and 20% of the time. Sometimes depression is also a prodromal or an initial sign that there's a dementia developing. And it's estimated that depression and dementia are mistaken for each other, as I said, in the general population, as well as with people who may have intellectual or developmental disabilities. So if we look at this slide, we can see that the symptoms of depression and the symptoms of Alzheimer's or dementia are frequently very similar to each other. Somebody who's depressed may not pay attention to their appearance, and that's also common in the general population. That someone who's depressed is not going to be as likely to pick out, bright, attractive clothing because they really just don't have the energy. There may also be a change in sleep habits. It's very common that people with depression have early morning awakening, or they have difficulty falling asleep at night. People with Alzheimer's disease may have a sundowner syndrome where they're up all night, or they may just have a disrupted sleep pattern in general. We see appetite changes in depression. People either eat more food, eat more sweet things, or they lose their appetite. People with depression also, many times, one of the initial symptoms is agitation and anxiety. And in Alzheimer's, particularly with people with Down syndrome, the first sign that there's a dementia progressing is increased agitation and irritability. We also see in Alzheimer's increased apathy or withdrawal. That's another common symptom of depression, both in people with intellectual disabilities and in the general population. There's also a memory loss in depression because the depression affects cognitive functioning, so that people may not be able to read as well. They may not be able to think clearly because they have a clinical depression as a symptom. And memory loss or memory decline is also very common with Alzheimer's.
There's many different challenges to a differential diagnosis in depression versus dementia. Individuals with intellectual disability and developmental disability may not be able to consistently and accurately describe their experience and feelings, lack the ability for a self-assessment. Reports by caregivers may be influenced by caregivers' tolerance level, by their beliefs about the individual's behavior, setting in which behavior is observed, and the caregiver's own psychological needs, the caregiver's own viewpoint. Or you also have the problems of aging caregivers that have their own medical issues occurring, and they're not good reporters. Symptoms of weight loss and gain, sleep changes may be a result of psychotropic medications. So you want to have your medication assessment. Some symptoms of depression, for example, self-injury, may be part of an individual's typical behavior patterns. It's often difficult to diagnose depression in someone who is aging and also has IDDD because that person may not be able to share his feelings, and the person may not be good at assessing how he or she feels. And as I said before, caregivers are not always accurate reporters, so you need to ask more questions to confirm what they're telling you. Do your own visuals. Common symptoms of depression, such as weight loss, sleep changes, like I said, also can be attributed to medication side effects. So you've got to rule out which is the source before you can figure out the solution to the problem.
So it's particularly important to make a differential diagnosis between dementia and depression because it affects the way you're going to approach it. It affects treatment and it affects outcomes. The changes that occur in depression are treatable and they're even reversible. It's also important to consider that depression may be a precursor or a signal that dementia is about to or is beginning to occur. person-centered planning is a tool in diagnosing and addressing both dementia and depression. And it should be the foundation in considering future supports and in working with the person. So as part of making a differential diagnosis, consider some of the recent changes that may be having an impact on the person's ability to cope. You know, has someone passed away, someone that the person was very close to, a family member or a long-term caregiver, a friend who the person knew at work, maybe the person always ate lunch with one particular individual and that person has moved or has passed away or has become very ill. You want to explore these issues with the person because someone with an intellectual and developmental disability may not volunteer that information. They may be brooding on it and they may be aware of it, but they may not be able to share it or be able to initiate sharing it in a conversation. You might want to look at if the person has had to move to another living arrangement. Maybe the person has lived at home with a sibling or with parents, and because of that person's declining health, they've had to move. Has the person, you know, experienced a change in their ability to see or to hear? That can contribute to a depression. And has there been a change in the external routines at work or at home? A change in the frequency of visits with someone that they are very attached to. So it's very important to work patiently and carefully with the individual. He or she may feel that something's wrong, but they may be unable to identify the source of that feeling. They may not volunteer that they're feeling sad. They may not be able to link it with something external that's occurred.
Now, there's ways to improve outcomes. You know, use a standard classification system for dementia and Down syndrome. Educate caregivers on how to recognize changes. Early diagnosis affects outcome. We've discussed this multiple times already in terms of Alzheimer's. You know, knowing what the cause is or when, you know, when it has started can affect outcome in dementias. Long-term follow-up should begin at age 35, especially, you know, particularly with someone with Down syndrome because of the early onset of Alzheimer's. Assess cognition and ADL skills and monitor for changes at least annually. So at the time of the annual physical, you want to have all your information compared to that baseline that you started with and keep comparing back to it. You know, are there changes? What do you see in your labs? What do you see that's different? That is this person losing communication skills that they previously had? Recognize the need for intellectually stimulating environments. You know, sometimes we forget, you know, if you don't give someone something to make their day interesting, to give them responsibility for themselves, they start to stagnate. Remember, memory loss is not the first sign. You usually will see behavior and skill changes first. Any questions?
We do. Okay. We have a hand raised from Kimberly. Kimberly Scott, I'm going to unmute you now so you can go ahead and ask your question.
Can you hear me?
Yes. Can you hear us?
I can. I was just wondering, you have a lot of really good websites, and what you send us to download isn't your whole PowerPoint presentation. Is there any way that we can download your whole PowerPoint presentation so that we can get those websites that you have at the bottom of each screen?
Absolutely. The entire PowerPoint will be available on the Resources for Integrating Care website, including, you know, our pictures and our voices. And, you know, please go ahead and download it. We also included with the presentation a list of suggested readings, some handbooks that we recommend looking for online. There's a tremendous amount of material out there. And it would be great if you know, well, I mean, I would be honored if you downloaded the PowerPoint, but I think you should also look at those suggested readings and the bibliography because there's a lot in there that would be very useful.
Okay, and also, actually the PowerPoint presentation itself, the PDF version, and all the handouts are available now. It's www.resources-for-integrated-care.com/webinar/series/RRTI. When you go to the website, you'll see on the right-hand side a quick links section. So you can click on, it's the first item that says professional development webinars. If you go down to the behavioral health series, just click on that and you'll see everything there to download. So we do have another question from Tracy. From the perspective that it's not always dementia, on the clock drawing, if the image drawn has the numbers 1 through 12 and then repeats the numbers 1 through 12 all on the right-hand side, is that more indicative of a stroke than dementia?
Oh no, what do you think, Linda? I would say you have some, spatial problems going on there. It could be indicative of a stroke. It could be indicative of peripheral vision field changes. It could be indicative of blurred vision, and you're not visualizing the difference of what you're writing. It's definitely indicative of more testing.
And I think what Linda said is, something like that, you really want to go to your network of healthcare providers. You want to have the baseline. I mean, I think what would be particularly significant is if 6 months ago that person was able to draw a clock drawing with the numbers appropriately placed and not repeated. That would be a real red light.
Yes, absolutely.
Okay, so we're going to go ahead and move on. Again, continue to type in questions. They can be about the current section that we're discussing next, or they can be about issues that we previously discussed, and there'll be another opportunity for questions and answers. So we're going to discuss considerations and resources for helping individuals remain independent as long as possible, and ways that people can be supported to make informed decisions about their care, even as their cognitive abilities begin to decline. So the Edinburgh Principles offer proactive, ethical, and person-centered practices for identifying, developing, and implementing supports for individuals who are experiencing dementia. These were developed through a collaboration between professionals from the University of Stirling, which is in Scotland, University of Albany in New York, and the University of Illinois at Chicago. They were developed in 2001, and they were designed to be internationally relevant because individuals all over the world who have intellectual and developmental disabilities are living longer, and many of them are experiencing dementia. So the goal was to develop some practice guidelines that would be relevant no matter where you lived. You can access a copy of the Edinburgh Principles at the website that's on the slide. It's www.albany.edu/aging/IDDD/Edinburgh.htm. But you're going to also find these. I mean, I think if you did a Google search and just typed in Edinburgh Principles, you would come up with them because they're used very comprehensively throughout all of the efforts that are being made to develop guidelines for working with people with IDDD who are aging. So what the principles are is to adopt an operational philosophy that promotes quality of life. So somebody is experiencing the initial signs of dementia or cognitive decline. You want to focus on preserving that individual's quality of life. It's not a death sentence. It's something that happened to the it's happening to the person. It's going to require some changes in going forward and making plans for the person, but you want to have quality of life preserved. You want to affirm that the individual strengths guide decision making. So you want to come from what we call a strengths-based focus. Yes, the person is losing skills, but the person continues to have skills. You want to focus on the skills that that person continues to have, and you want to make the most use of them. And as Linda was saying, which was a few minutes ago, you want to preserve those strengths through providing a stimulating environment. You don't want to give up on the person because there's a diagnosis of dementia. You want to involve the individual and the family in all planning and services. Even though the person is going to be experiencing a decline in his ability to advocate for himself, be strength-based. You know, continue to work with that person with using the skills that he continues to have. You want to ensure the availability of appropriate diagnostic and service resources, and that's why we've talked so much about baseline, about the diagnostic screenings that are available, how to recognize that some of them may not be appropriate for use with somebody with IDDD. And you want to make sure that the people who are your service providers, your healthcare professionals, are aware that the SAGE may not be the optimal test for somebody who has you know, a moderate to severe intellectual disability. You want to plan and provide supports to optimize the person's ability to remain in the community, because the community is a place where they're familiar, where their routines are something that they enjoy, where they're going to have more contact with the people that they care about. Even as their skills decline, it makes a difference to be in a situation that's comfortable and feels safe. You want to ensure that people with an intellectual disability have access to the same dementia services provided to others in the population. And this is really something that's in this country is protected through the American Disabilities Act, but you want to be an advocate for that individual and make sure that if Office of the Aging, for example, offers a support to anybody in the general population, that that's also available to the individual with an intellectual disability. So it really calls upon us as practitioners to be strong advocates for the people that we're working with. You want to ensure that community dementia services planning also involves a focus on adults with intellectual and developmental disabilities. You know, I think it's less so now, but there is a stigma associated with people with IDDD. And as practitioners, part of our job is to dispel that stigma and to really make other people aware that these individuals have the same rights. They're often wonderful friends and companions, and they really deserve to take a strong place in our community. You want to ensure generic, cooperative, and proactive strategic planning across relevant policy provider and advocacy groups, which involves a consideration of the current and future needs of adults with ID and DD affected by dementia. This is like a really big job. It may not be something that's within our scope of practice as people who are, you know, working directly with individuals, but it's important to be aware of what's happening in the world around us. And that's why I think it's so important to make use of the websites and handbooks and the other resources that we've included with this presentation, because that will give you kind of a, you know, an awareness of what's happening not just in your state, but also in our country and also in the world. So how do we go about implementing the Edinburgh Principles? It's important to recognize that these are designed using a person-centered and strength-based approach. You want to work with an individual as a collaborator. You want to learn about what his or her wishes are, what his or her concerns are, what are his or her fears. If that person's afraid of the dark, you want to make that known to other people. You want to document how that person wants his or her life to progress, because you know there's going to come a time when that person is not going to be able to communicate that for himself. You want to understand and make sure that caregivers understand that the focus is no longer on developing new skills. You don't want to stress the person with teaching him or her how to do something new, but you really want to support the abilities that the person currently has. So the focus is strength-based, and it's, when we say strength-based for somebody with dementia and with an evolving dementia, that focus is on the skills the person currently has. You want to talk with the person, his or her caregivers, his or her family members. What does that person think about this? Has this person noticed anything? Is the person afraid of what's happening? Does the person want to age in place? Is it a priority to stay in this particular congregate care setting, in this particular apartment? What's important to the person? You want to continue ongoing and regular assessments. You want to provide education to caregivers and to families and to the individual. You know, if the person is able to participate and in understanding this, you don't want to scare them, but you want to make them aware of what's happening. Even if what you're teaching is how to ask for help, how to notice when they need to reach out to somebody, that's a valuable tool to give the person. You want to develop a network of qualified professionals who are skilled in assessing individuals with intellectual and developmental disabilities. So people who are aware that they may need to use a different diagnostic tool. They may need to look at that baseline that you have prepared for them and that you continue to update and keep current. And you want to learn about community resources for people with dementia in your community and explore these to see if they're of interest to the person or if they're helpful to the person. You know, maybe the person has been working at a job for many years, and because of their declining skills, they're no longer able to participate in the job. But maybe they would really enjoy going to a senior center. That's something you should explore with the individual. We've had success with people going to senior centers.
Oh, yeah.
And really enjoying them. I know one woman had a beautiful voice. She'd never had the opportunity to sing where she worked, but they had music at the senior center in her town, and she really blossomed it and definitely improved her quality of life.
As people's abilities decline, their cognitive skills decline, you become their advocate. You are the most essential person to that person because as their advocate, as their health care professional, you're the person that's going to ensure that they are getting the services they need in the right kind of a health care setting to obtain those services. You need to ask those important questions like, how does this person communicate? And share that from person to person that's involved in that person's life so that they understand what their communication capabilities are and how they're diminishing. What are his or her capabilities? How does he or she communicate their needs? What does he or she need help with? Do they need toileting help, dressing help? Do they need to be fed? Do they just need their food cut up and prepared for them and they still have the ability to feed themselves? Then you want to maintain that. You want them to still be given the opportunity to feed themselves. Can they choose an appropriate diet? Encourage them to make those choices. Encourage people around them to allow them to make those choices as much as possible. Are they on a special diet? So still give them choices that are in that special diet, so they still have the opportunity to make choice. What does he or she need to feel safe and confident to protect their personal safety in their environment? And you need to have conversations with the caregivers. As caregivers age, like we said before, they may no longer be able to provide a previous level of support. So you're always going to need to keep reassessing the homes that your people are in. Is that caregiver capable of still providing that care? Do they need a change? Is that person now not safe in that home? Are they wandering? Are they in a home where they can walk out the door at night and no one is aware of it? We had a terrible circumstance happen in one of our homes where the person wandered out in the winter and was found in the snow. They had frozen. It was a horrible circumstance that had happened, and it kind of enlightened us to the fact that wander guards, door alarms, all these things may need to be put into place. And if that home is not able to have those supports put into place, then maybe it's time to change homes or change the level of restriction around that person so that they are safe. Maybe it's time for that nursing home placement or a group home placement rather than a family care home placement to provide that level of safety. Encourage family caregivers to identify their personal goals for retirement and health care. Discuss the plans for their family members' care who will care for this person in their absence. So we have people in our system that are living with a father who is aging. Is the person's sister willing and able to take their brother in as their caregiver, or is this something that they really don't want to do? All those things need to be thought about ahead of time, not when the father is now hospitalized because he's too ill to take care of the person in his home. Help family caregivers develop a wish list for their family member and help them to prioritize and actualize these wishes. collaborate to identify community resources to make their plans and wishes a reality. These are all things that need to be taken into consideration, that are conversations you should be having with the caregiver and the person in their care.
And when we talk about working with this from a strength-based perspective, you want to preserve the person's strength. So with the tragedy with the woman who had cognitive decline, and people, and this is many, many years ago, people weren't aware of how impaired her judgment was, that support of a door alarm or whatever was not in place. But we have the opportunity now to do early diagnosis and to start thinking ahead. Many communities actually provide congregate care settings that are progressive, so somebody can live in in an apartment or a supported apartment as long as he or she is capable of managing that, but then maybe move to another area of that same apartment complex where there's additional care. And that's the kind of conversations you want to be having with caregivers and with the individuals. What is it that they want right now while they're still able to make those decisions? How do they want to plan for their future?
Or to keep that person in the apartment. Maybe they're no longer able to get out and do their own grocery shopping, but there's people we could put in place to do that shopping. Sit down with them, find out what do they want for that week, what do they want set up so that they have their meals for the week, because they're still able to do some things for themselves, but they're no longer able to get to that grocery store to get the needs of the food for the week. There's also Meals on Wheels. There's many programs that can be put into place that would give that person the opportunity to stay living in the apartment that they have declared this is where they wish to stay. Their friends, their things that they like to do are in the area of that apartment complex, and they're still somewhat able to maintain themselves. So with some supports in place, maybe they can continue that placement for a little longer, and maybe at some point you have to make that change.
Many of the supports we're talking about are available through the home and community-based waivers. Many of them are available through your local Office of the Aging. It's important to remember that people with a developmental disability are eligible for the services that any other member of the community is available for. Having an intellectual disability or a developmental disability doesn't exclude or preclude their access to those services.
So if you're optimizing quality of life, it's the same thing we've just been talking about. Support and enable that person's existing abilities. We're not trying to teach new skills. We're trying to preserve the skills that still exist for as long as possible. We know decline is inevitable with dementia, but there are supports along the way that can maintain that person what's familiar. Best thing you can do for someone with dementia is keep them in the environment they're most familiar with. There's a safety net to that. They know where their dresser is, where the bathroom is, where their bed is, where their eyeglasses are kept at night, so that they can get up, put them on, and get to the bathroom at night safely. I mean, those things are familiar routines. They need to be maintained. Familiar environment, it needs to be maintained. There's a predictability and a familiarity to help a person feel more secure when they're in the environment they're used to being in. Safety first, increase staff, closer supervision, monitor nutrition intake closely, review environments regularly for risks, trip hazards, poor lighting. Dehydration is such a big problem because you're dealing with someone who is aging, plus has dementia, maybe still trying to live on their own. So, are they getting adequate hydration? Dehydration is one of the biggest reasons why we end up with people in ERs, because they weren't adequately taking in fluids. Encourage exercise if a person's condition permits it, can help maintain physical and mental abilities. Support socialization, plan activities that the person enjoys, provide memory aids to help the person recall the names of familiar people. That socialization also helps that person preserve the memories that they still have. Alzheimer's dementia is progressive and irreversible, but the process can be slowed and the person's quality of life can be enhanced as much as possible for as long as possible.
So there are quite a few collaborative efforts out there, and these are opportunities for you to learn more about dementia and also about the resources that are available. The National Task Group on Intellectual Disabilities and Dementia Practices is a collaborative effort between the American Academy of Medicine and Dentistry, the Rehabilitation and Training Center on Aging and Developmental Disabilities, which is at the University of Chicago, and the American Association on Intellectual and Developmental Disabilities. Right now they have a wealth of information available at the website. It's www.aadmd.org. I know American Academy of Medicine and Dentistry really doesn't sound like your first choice for finding out information about ID and DD, but it is an incredible, it's like a treasure trove. There's information that you'll find there on assessment and evaluation. They also talk about developing assessment tools that are designed specifically for people with intellectual and developmental disabilities. They talk about how to develop supports. They provide articles and resources for developing supports in your own practice. There's articles on advanced directives, which we didn't really cover exclusively in this presentation, but you know, we've kind of discussed working with the person to identify what he or she would want going forward in their lives, and that could be incorporated into an advanced directive. All of the information comes from a very person-centered perspective, you know, where the individual is really at the center of what you're building in terms of resources and supports. There's information for aging in place and considerations for discussing that and for developing resources and providing the necessary supports, and just a lot more. It's really a wonderful website, and something that I really type in yes. Asking if everybody wants audio. Should I type in yes? Yeah.
Wonderful. Jill and Linda, welcome back.
What was that?
Hi. We seem to have lost audio, but we are back. Can you hear us?
Yes, we can.
Thank you.
Thank you. Okay.
Shall we proceed?
So I'm really sorry about that. But as I was saying earlier to Linda, when I first started doing presentations, how do I hide that?
Can we just go on with that there?
What's going on? I just wanted to hide the technical screen.
Go on with it there before we lose anyone.
Okay. So I apologize for that. Anyway, what we were talking about is the National Task Group, and I wanted to go over some of the projects and initiatives that the task group has committed itself to work on. The first thing is they wanted to develop a draft of an early detection screen for identifying dementia-related changes. And this was the screen that we presented earlier, and I did provide you with a PDF of that. and a link. And we, I think that is a huge step in providing early diagnosis and so forth to individuals with IDDD. They also are working on developing practice guidelines for people with IDDD and dementia. They're identifying models of support that are particularly effective for people with IDDD. They also have a publication which you can access online. It's called My Thinker's Not Working. It's a handbook that is full of statistics, information. I think it also includes references to the Edinburgh Principles. It's very comprehensive and very useful. They've also provided a handbook called Guidelines for Structuring Community Care and Support for People with Intellectual Disabilities affected by dementia. And these PDFs are available at www.aadmd.org, and that's at that website. That's a collaborative effort of the three areas. The University of Chicago and the American Association on Intellectual and Developmental Disabilities, as well as the American Academy of Medicine and Dentistry. So as I've been saying, the really important thing to do is to learn as much as you can, be as knowledgeable as you can, and be as comfortable as you can be with the knowledge that you have, because you're going to be the people who are going to be interfacing with caregivers and with family members, as well as with the individuals that you serve. So you want to know what you're talking about, and you want to be able to talk about it in a way that someone who hasn't read all this stuff is going to be able to understand it. You want to stay away from using really highly technical terms. We've used them here for your information, but in working with an individual or a family member, you want to use words that are kind of user-friendly. This is a list of some of the handbooks that are available on the web. And I believe these are also available at the Resources for Integrated Care website. The first one is from Vermont, and this is a very accessible and easy-to-read resource with frequently asked questions. It provides links to additional resources, including the Edinburgh Principles, and it has extremely concrete recommendations for working with individuals who are experiencing declining cognitive skills and dementia. One of the sections in it reviews common behaviors that you might see, and as you recall, with somebody with Down syndrome who's experiencing dementia, the first sign may be a change in behavior, and those behaviors may be really difficult to manage in a congregate care setting, and this actually provides like a whole little worksheet of how you can understand that behavior, figure out what's being communicated, and then how you can maybe manage your own response as a caregiver to that behavior, because it may be difficult or even impossible to change the individual's behavior. Aiding older caregivers of persons with intellectual and developmental disabilities. This is a handbook that was put together at the University of Albany as part of their whole department on aging and geriatric care for individuals with IDDD. And it has some great information that you would want to share with caregivers. It has some worksheets that caregivers themselves can complete. And this is probably more specifically for people who are family members of individuals with intellectual and developmental disabilities. And again, you can easily access this either at the Resources for Integrated Care website or by going to the Albany website. And then there's Aging and Down Syndrome. This was put together by the National Down Syndrome Support Organization. It's a PDF that you can access on their website, and it's very useful for providing direct care to individuals with Down syndrome. It's also extremely family-friendly, so if you're working with family members, you might want to download this and offer it to them, or you may want to show it to them and encourage them to download it themselves, because it'll be really, a resource that they can go to again and again in working with their family member. I highlighted these three handbooks because I thought they were probably the most useful, but there are many others, and depending on who you're working for and what the person's needs are, I've included a list of them and the suggested readings and resources that accompany this presentation. So some of the useful websites that you might want to look at is the Rehabilitation Research and Training Center on Aging with Developmental Disabilities. This is at the University of Illinois at Chicago. It has some great resources. There's a bibliography on dementia care. There are fact sheets. There are also some assessment tools and instruments, links to reports that have been done and to research that's ongoing. There's also information on conferences that you may want to attend, you know, and there's contact information for people who are doing cutting-edge research in the field. Another useful website is the School of Social Welfare at the University of Albany, which is part of the SUNY system. This has a lot of information for caregivers as well as information on what to be aware of if you're working with individuals with IDDD who may be experiencing dementia. The Institute on Aging at the University of Wisconsin also has some excellent resources. There are articles and research on policy and practices in healthcare for the aging. And then the Institute on Community Integration at the University of Minnesota. It's a University Center of Excellence, what's called a UCED, and that also offers a wealth of resources, information, training opportunities for services, consultation services, and I encourage you to look at that as well. And you know, on the suggested reading and resources, there are even more websites and opportunities for things that you can look for. Assuring that you're informed and aware of recent research and developments will support your practice, and it will ensure that you and the individuals that you're serving are getting optimal care. These resources can also help you identify local resources in your community, and those can be used to help individuals sustain their abilities and remain you know, in their homes longer so that they can age in place. So before we move on to questions, we have a brief true and false test for you. Lisa, do you want to explain how this is going to work?
I am launching each poll question, and it will appear on your screen like it should right now. And all we ask, they are all true and false questions. So Linda and Jill will be going over the question and the answer and explaining why the answer is what it is, so that will give you enough time to choose your answer.
Okay,
and then we will, I'll close the poll and then we'll go on to the next one. So hopefully we can get through this fairly quickly, and it's looking like most people have answered this one already. So that's good. That's good. That's good. That's wonderful. So why don't you go ahead and start the first question.
Dementia is a process characterized by cognitive decline and an impaired ability to function. The answer, of course, this is true, and it's the basis of our entire presentation. And it's a process that is characterized by this decline and change in functional ability. And that's how you're grading it, and that's how you're monitoring it.
Okay. So the thing to remember with this is that dementia is a process. It's going to be progressive, and it's going to be gradual in most cases. In a moment, we're going to move on to number 2. Okay. Number 2, the standard assessment tools for dementia are reliable tools to assess dementia in an intellectual and developmentally disabled population. Is that true or false? Would you want to use standard assessment tools such as the SAGE?
Or the mini mental status exam.
Linda knows them all.
Balance test. Do we get a feel for answers?
So, Linda, is this true or false, number 2?
This is false because we have varied baselines amongst our intellectually disabled, developmentally disabled population. So standard assessment tools are geared towards someone who has reading, writing, basic computation skills, motor skills, and in the population that we're talking about, those skills may or may not be there, so the test would really need to be geared towards what their baseline is.
Okay, number 3. Alzheimer's disease is a rare form of dementia unlikely to affect individuals with Down syndrome. Is that true or false? Okay.
That's false. The IBR study clearly showed a connection between Down syndrome and Alzheimer's. So it is something that definitely affects Down syndrome in higher rates as they age.
And Alzheimer's is also the most common form of dementia, so it would not be considered rare. So the answer is definitely false.
People with Down syndrome are dying at younger ages than previously.
So this would be definitely false. As we've talked about, people with Down syndrome are living to be much older than they used to. Currently, many of them are living into their 60s. If you go back to the 1930s, individuals with Down syndrome often had a life expectancy of around 9 years of age.
Can I read the next one?
Okay.
I'll answer.
Oh, okay. The Down syndrome mental status exam, which is the DSMSE, the test for severe impairment, or TSI, and the caretaker questionnaire are useful tools in diagnosis of dementia in the IDDS, that would be Down syndrome population. Is that true or false? Okay, Linda, what's the answer?
The answer to that is true, and these are the tests that were developed taking into consideration intellectual deficits, motor and cognitive deficits. So they were developed specifically based on a person's baseline in Down syndrome. The TSI, the test for severe impairment, looks at motor skills. It looks at cognitive skills that would be affecting someone in a severe range of developmental disability or intellectual disability. And they are definitely useful tools because they are more specific to someone's baseline.
Oh,
the answer is true.
Okay. Number 6, a baseline of capabilities prior to dementia is an effective tool to diagnose and recognize symptoms of dementia in the IDDD population. Is that true or false? Okay. The answer to that question is true. And as we've been talking about throughout the presentation, a baseline is probably your most valuable resource and tool in making sure that you are aware of the early signs and symptoms of dementia in somebody with IDDD. And we've also been talking about how important it is to get an early diagnosis. It's important for developing future care for the individual and also for ruling out the possibility of those signs and symptoms being the result of something other than Alzheimer's, since many dementias can be treated.
Symptoms of depression and Alzheimer's can be similar in individuals with IDDD. True or false? That would be true. When you look at the chart comparing symptoms of depression versus Alzheimer's, they are very similar, and that's how you would make your differential diagnosis. Besides doing lab tests, physical exam, that's how you would make your diagnosis for someone with IDDD.
So with depression, you know, if you suspected a depression, you might want to talk to the person about changes in his or her routine, if he's lost a loved one. Individuals with IDDD may not, you know, be straightforward or able to really self-report if they're having feelings of sadness or other symptoms that are associated with depression. Okay. The Edinburgh Principles recommend institutionalization of individuals with intellectual and developmental disabilities who have mild to moderate dementia. Is that true or false? That is false. The Edinburgh Principles recommend maintaining the individual with supports in the community and aging in place to the extent that it's possible, and to take a very person-centered, strength-based focus on caring for somebody with dementia.
Working on preserving that person's capabilities, not teaching new tasks, maintaining the tasks that they're capable of. The first sign that a person with Down syndrome may be experiencing dementia is usually a change in behavior. True or false? Okay, someone with Down syndrome, the answer is true. Someone with Down syndrome may not have the communication skills to express what they're feeling, whereas a behavior is something that they can demonstrate what they're feeling.
Some of the changes in behavior that you might notice are increased agitation. Somebody who used to be very social may begin to withdraw or be very isolated. So those are not necessarily a change in memory, but they would definitely be an indication to look further. Planning future supports for an individual with intellectual or developmental disabilities should not include the individual, since it would be upsetting for him. Is that true or false?
Well, that's false, because we definitely want to include the individual. We want to support that person's decisions, support their autonomy, support their strengths for as long as we can, so that they can live in the environment or the setting that they want to stay in.
And the person may be fearful of what's happening, but you know, a skilled practitioner can present information and talk about future plans in a way that's more supportive, you know, clarifying things that may be confusing for the individual as reassuring, and that would be the approach that you would want to take. But you would definitely not want to exclude the person or diminish that person's autonomy in any way. Okay, so hopefully everybody got everything right. And if you have any questions, or there are any points that you want to bring to our attention, or any discussion you think would be useful at this point, please raise your hand in the GoToWebinar format, or type your questions in, and we'd be delighted to speak with you. Are there any questions? No questions. Thank you. Thank you very much for your time, and it was a pleasure to present to you.
Today, if you do have questions after this webinar presentation, please feel free to email me, Lisa, L-I-S-A, at nyrehab.org. Questions could be about anything, about the webinar itself, the content, and I will make sure I will answer to the best of my ability. Also, once this webinar ends, a tab will appear in your browser prompting you to complete the evaluation survey. It is required that you complete this evaluation survey in order to receive the 3 contact hours each: Michigan Social Work Continuing Education Collaborative, National Board of Certified Counselors, New Hampshire Nurses Association, and the National Association of Social Workers. If you're unable to complete the survey at the end of the webinar, you'll receive an email tomorrow with a link to complete the survey at that time if you have not already done so. Also, I will be emailing certificates of attendance. Please allow us 5 to 7 business days to get those to you. But after that time, if you have not received it, please feel free to email me. Again, Lisa at nyrehab.org.